আমাকে চলে গেল কেন? ওনাকে দাঁড়াতে বললে। ওনাকে বললাম এটা লাগবে। প্লিজ। বললাম যে সেট করে দেবো, সেট করে দেবে। ওই যে ওনার এটা আসবে না, এটা আসছে না, অ্যাপলে করা রয়েছে, এটা 2007, ওটা আসবে না। সেট করে দিয়ে চলে গেল। আয়া তো জানা, এটার সাথে কোনো কানেকশন করে?
এটার সাথে তো কানেকশন করা আছে।
হ্যাঁ, এই যে ঠিক আছে, আপনি থাকুন, যতক্ষণ এটা শেষ হয়ে যাবে। ঘরে একটুখানি প্রবলেম হচ্ছে। হ্যাঁ, ঠিক আছে। Okay, Dr. Varun Singla, he is from PGI Chandigarh. Over to you.
I'm sorry I could not get some of my tables on this WordPoint of this computer, so I used mine. Respected chairpersons, judges, and my dear colleagues, I am Dr. Varun Singla from Postgraduate Institute of Medical Education and Research, Chandigarh. My topic today is a study on steroid versus platelet-rich plasma in ultrasound-guided sacral joint injection for chronic low back pain patients. And I think it's apt to the theme of the conference, that is the recent advances in pain. For the introduction part, chronic low back pain, as we all know, constitutes a majority of pain complaints with a prevalence of around 60 to 70% in US population. The SIJ being implicated as the primary source of pain up to 10 to 27% of the patients. Steroids are being widely used to treat sacroiliac joint pain because of their anti-inflammatory action, but it has been seen that their duration of pain reduction is usually short term. So treatment modalities which are being currently used do not in general address the disease process itself. There is clearly a need to investigate treatments that are more widely applicable for symptom management and which also direct the disease process itself. Since platelets are known as the major source of healing factors within the blood clots, and idea of concentrating them at injured site could somewhat accelerate and optimize the healing mechanism, stimulated the use of PRP in our study in the sacroiliac joint. So, as to the mechanism of platelet-rich plasma, it enhances the tissue healing, cell proliferation, cell regeneration by delivering various growth factors and cytokines. And it is hypothesized that it may have a longer lasting effect as compared to steroid. The primary objective of our study was to assess the efficacy and safety of PRP compared with the methylprednisolone in ultrasound-guided sacroiliac joint injection for chronic low back pain patients. Secondary aim was to assess the improvement in functional disability by modified Oswestry Disability Questionnaire and health survey scoring. This is SF-12. Methods. This was a prospective randomized open blinded endpoint study. After institutional ethics committee approval and it informed consent, 40 patients with chronic low back pain which were diagnosed with sacroiliac joint pathology were randomly allocated into two groups by a computer generated random table. Group S, that is the steroid group, received 1.5 ml of methylprednisolone and 1.5 ml of 2% lignocaine with 0.5 ml of saline, the total volume being 3.5 ml. While the patients receiving PRP received 3 ml of leukocyte-free PRP with 0.5 ml of calcium chloride. Calcium chloride has an action to release the growth factors from the PRP, from the alpha granules of platelets. We assessed patients by the use of visual analog score, modified Oswestry Disability Questionnaire, and short form health survey at 2 weeks, 4 weeks, 6 weeks, and 3 months. These were the inclusion and the exclusion criteria. Patients included were chronic low back pain patients of moderate intensity for more than 3 months, patients with more than 3 out of 6 positive provocative tests, positive imaging findings, and failure to achieve adequate treatment with conservative management. The exclusion criteria were systemic infection or localized infection at the entry site, symptomatic foraminal or central canal stenosis, any potentially confounding disease like disc or facet joint pain, patients having active radicular pain, and also the patients who were immunosuppressed, like history of tuberculosis or AIDS or cancer, diabetes, or surgery less than 3 months. Patients with allergy to medications were also excluded. Patients who had a contraindication to the use of PRP were also excluded. This was the statistical analysis. We used IBM SPSS software and GraphPad software. Especially, I would like to tell you that we used repeated measure ANOVA for assessing the VAS, MWQ, and SF12, while we did a multivariate analysis to assess the reduction of VAS, and we calculated the adjusted odd ratio accordingly. These are the results of our study. As you can see in this table, these are the two groups. This is the PRP group and this is the steroid group. So as you can see, the pre-injection, at the pre-injection 2 weeks and 4 weeks, there is not much difference in the VAS scoring. While at 6 weeks and 3 months, there is comparatively statistically significant decrease in the VAS in the PRP group. The same in the figure, as you can see, the patients receiving PRP had sustained relief in pain, while patients receiving steroid had an early decrease in pain, but while it deteriorated over the 3-month period. This is, we calculated the reduction in VAS, which was kept as more than 50% in number of patients. So we calculated as to how many patients had reduction in VAS greater than 50%. So as you can see in this table, at 4 weeks, around 70 to 75% of patients had more than 50% reduction in VAS, while at 3 months, 90% of the patients receiving PRP had greater than 50% reduction in VAS, while only 25% were remaining in the steroid group. We did the binary logistic regression analysis to calculate the odds of achieving reduction in VAS, which was found to be 10.9 for the PRP group at 6 weeks and 37.3 at 3 months for PRP group. Similarly, for assessing the functional disability, we assessed the modified Oswestry disability questionnaire. Similar results were found for the functional disability. That is, at 6 weeks and 3 months, there was improvement in MODQ score in the PRP group. As you can see, there was sustained relief with PRP, while the steroid group deteriorated over a period. This is for the SF12, the physical component summary of the short form health survey. This assesses the functional disability, emotional and functional disability. So similar results here also. PRP group at 6 weeks and 3 months has a very good result, while steroid group is deteriorating as we go further. This is the mental component. This is the mental component summary of short form health survey. This is the emotional component of the patients. So similarly, patients receiving steroid had decrease in there was no improvement or deterioration in the SF12 score, while patients receiving PRP had a good score over the period of 3 months. Now to the complications of PRP. This is of special interest. We assessed the complications. So we found that patients did not have any major complications in both the groups, but PRP group had post-injection pain and stiffness, which was more in the PRP group, but it was transient, local and mild in nature only, for around 2 days. Discussion part, patients receiving PRP had more and longer lasting improvement in pain and functional limitation, and also more number of patients receiving PRP had pain relief. So the effect of PRP was sustained, while patients receiving steroid had deterioration of initially improved VAS score at 3 months. The efficacy, that is the reduction in VAS greater than 50%, as to how many patients had a decrease in VAS, it was like the efficacy of steroid decreased, while that of PRP was better with time, as we go on to see for the 3 months period. So it can be hypothesized that steroids are effective in pain control in short duration, but PRP improves pain for longer duration. only anti-inflammatory factors which we are using, steroid we are using, they have anti-inflammatory factors and anti-inflammatory action. This may not be enough in improving disability and general health. Addition of growth factors which might enhance the biological environment and affect the tissue regeneration and tissue homeostasis, it would be needed. There's a cocktail of anti-inflammatory factors along with growth factors may play a vital role in improving the disability, pain, and general health of the patients. There were some limitations in the study. This study was a prospective randomized open-blinded endpoint study. So subjects were not blinded and there was a bias, subject bias. Follow-up duration of 3 months is not enough for chronic conditions like SI, sacral joint pain. And we assessed the clinical parameters only. This is the VAS, MODQ, and acceptable scoring. We did not look for the pathophysiological effects of the treatment on disease process as to if it is actually causing decrease in the degenerative process or not. Conclusion, intra-articular PRP injection is an effective treatment modality in low back pain patients with sacral joint dysfunction and provides sustained pain relief with improvement in disability and general health. These are my references. Thank you.
Thank you, Varun. I think it was a very nice idea for a study and well executed study also. A few of my queries are, did you take a unilateral disease or bilateral disease?
Unilateral, ma'am. Unilateral.
Only.
Yes,
So just injected 3 ml in one joint.
3.5 ml.
Okay, and how did you get the PRP?
PRP, we have a transfusion medicine department there. They prepare PRP. Actually, it's done like there is a biosafety cabinet in their department. So patient is taken to the department and the whole blood is taken around. That depends on how much volume of PRP is needed. So if we need 3.5 ml, we will need around 40 to 50 ml of whole blood. So it is taken from the antecubital vein of the patient, and we take around 50 ml of blood in an anticoagulated blood bag. So it is taken to the biosafety cabinet and it is centrifuged for around 1300 RPM for 15 minutes. We did, and there's a layer. Layer is formed. Downside is the RBCs, erythrocyte component. Upper one is the platelet-rich plasma and the buffy coat. So also this was a one uniqueness in the study was that we used leukoreduced PRP. That we use a leukocyte filter. We excluded the leukocyte part, which is shown to be a little better infection.
This was done just before the injection or how many days prior?
Just before the injection, ma'am. Just
on
before.
the day of the injection, you
On
made
the
the patient go and donate blood and get the PRP.
Yeah.
And you injected at the same time.
Yes, ma'am.
Okay,
Because
you
it-
don't store it. You,
No, the chances of infection also and the efficacy also decreases with time.
okay. And how did you come to the sample size?
Sample size, ma'am, we took around 40 patients. Which, I asked my statistician to do that. I really don't know how to do it. There was one previous study on steroid. I think Lucan et al. So they they put steroid, intra-articular steroid in the sacroiliac joint, and they found over a 3-month period they follow up the patients, and they